Good evening, everyone. We are once again with Dr. Ajay Kher in his series of fluid and electrolyte disturbances and acid-base abnormalities. And today he is going to talk to us about metabolic alkalosis. He has already covered some of these concepts in discussions on the basics of these acid-base disturbances. And today he will go in depth to analyze the various causes of metabolic alkalosis, how do you make a differential diagnosis, and how do you go ahead and treat metabolic alkalosis. Over to you, Dr. Kher.
Thank you, Dr. Jha. And this is the last in this series. And so I'll start with a little bit about bicarbonate homeostasis. Some of these things we've discussed before. The metabolic alkalosis generation and maintenance, how they're slightly different and how both are important. And then evaluation of someone with metabolic alkalosis and then treatment of metabolic alkalosis. So to start with, we'll start with how the body handles physiologically the bicarbonate. So this is from a study in 1949, and the black circles are one person, one volunteer. The triangles are second volunteer, and the open circles are the third. And what they did is they gave sodium bicarbonate by infusion, and they monitored their serum bicarbonate, which is in the x-axis here, and in the y-axis is how much bicarbonate was in the glomerular filtrate, and out of that how much was reabsorbed and how much was filtered. And as you can see on the curve, that while the serum bicarbonate goes from 12 all the way up to 26, all the bicarbonate that is filtered is all reabsorbed, and the curves only splay when the bicarbonate increases beyond 26, and the reabsorption of bicarbonate plateaus at that serum bicarbonate, and the excretion starts increasing exponentially based on what your bicarbonate is. So what it means is that 100% of your bicarbonate that is filtered is reabsorbed till your bicarb reaches 26, and after that the bicarbonate reabsorption plateaus, and you start excreting or releasing bicarbonate beyond that. The corollary of that is that if you develop metabolic alkalosis from whatever cause, the kidney will be able to excrete the extra bicarbonate and will get you back to a normal bicarbonate and normal pH, unless there is some additional impairment of the kidney's ability to excrete bicarbonate. And usually those additional factors could be hypovolemia or hypokalemia or excess aldosterone. And these are one of these, or at least a combination of these, are mandatory. Otherwise, the kidney would be able to excrete the extra bicarbonate. And no matter how you generated the alkalosis will dissipate because the kidney will be able to excrete it. So another study that was done in the 1970s, this is in a similar study, but done in a single patient. And again, the bicarbonate that is filtered is on the y-axis and the plasma bicarbonate on the x. And the black circles are when they gave sodium bicarbonate by infusion after they had already given them some diuretics to volume deplete them to simulate volume depletion and metabolic alkalosis. And the triangles are where there wasn't any volume depletion, and so as they infused sodium bicarbonate, there was an increase in the extracellular volume. And so as you can see, once you get the bicarbonate of 26 in a normovolemic state, the person is able to excrete the extra bicarbonate and there is no extra reabsorption, and with that the alkalosis would not be maintained. However, in the setting of previous volume depletion, what happens is instead of reabsorbing only till 26, the reabsorption of bicarbonate continues all the way up to a bicarbonate of 35. Again, the volume depletion is therefore maintaining or aggravating the metabolic alkalosis. So now we'll look at how this happens inside the body, and we'll see at the different mechanisms of metabolic generation, metabolic alkalosis generation, and maintenance. So for generation, there are a few different mechanisms by which someone can generate the metabolic alkalosis. So this can be a loss of hydrogen or protons in the urine. It could be loss of hydrogen or protons in the GI tract from the stomach with vomiting or Ryle's tube aspirations or nasogastric tube aspiration. It can be administration of bicarbonate or equivalents of bicarbonate like acetate and citrate and lactate, in which case that is the source of the alkalosis. Or it can be a volume contraction around a constant bicarbonate, which is what can happen when you give diuretics. So this is how the metabolic alkalosis is generated, but unless there is things or factors hampering the kidney's ability to excrete the metabolic alkalosis, the kidney would excrete the bicarb and you would come back to normal. So the maintenance of metabolic alkalosis is a combination of things that can be there. It can be a reduced bicarbonate filtrate, which would be decreased GFR, whether it is just renal failure or volume depletion causing a pre-renal state. There is enhanced reabsorption, which can be with aldosterone, causing increased absorption, or it could be impaired secretion because of decreased chloride delivery to the distal tubule. And usually all of these are a combination that can happen in someone who's volume depleted, whether it is true volume depletion or effective volume depletion in the setting of heart failure or cirrhosis or nephrosis. Uh, Hypokalemia is a separate factor that can also maintain metabolic alkalosis. And the final factor can be an increased sodium delivery to the distal nephron, which enhances sodium reabsorption and leads to increased hydrogen ion or proton secretion and potassium secretion. And that also then maintains the metabolic alkalosis. So we'll see how this happens inside the cell over the next few slides. So recapping the proximal tubular cell and how it is one of the main sites of bicarbonate reabsorption. So it has multiple channels and ports. So the first and most important one, which generates all the energy, is the sodium potassium ATPase, which is on the basolateral membrane. And with that on the basolateral membrane is the sodium bicarbonate symporter. And on the tubular or luminal side, you have the sodium hydrogen exchanger. The carbon dioxide and hydroxyl ions under carbonic anhydrase uh, will be generating H plus ion and bicarb. The bicarb will get reabsorbed on the peritubular side, and the H plus or proton will be secreted into the tubular lumen. This proton that has been secreted into the tubular lumen will bind with the bicarbonate, and so the bicarbonate that is there is going to be reabsorbed through the secretion of the bicarb by the sodium bicarbonate symporter. So the bicarbonate that is filtered gets reabsorbed through this mechanism. In the setting of volume depletion, what happens is angiotensin 2 can upregulate the sodium hydrogen antiporter as well as the sodium bicarbonate symporter and upregulate the reabsorption of bicarbonate through this mechanism. In addition, the lower GFR will decrease the total amount of filtered bicarbonate in the setting of volume depletion as well. And so the amount of bicarbonate that needs to be reabsorbed to maintain the bicarbonate is also decreased. Now let's look at the distal tubule, in which we have three cells. We have the principal cells, which are on the top. We have the intercalated type A cells, and we have the intercalated type B cells. In the principal cell, the energy comes from the sodium potassium ATPase, which is again on the basolateral side. And on the luminal side, we have the ENaC channels, or epithelial sodium channels, and we have the ROMK potassium channels. The sodium ENaC channels will help absorb the sodium into the principal cell, which will then be extruded to the peritubular capillaries by the sodium potassium ATPase. In the intercalated type A cells, which are the primary cells that help in correction of acidosis, there is the hydrogen ATPase, which is on the luminal side and is the source of the energy that mobilizes the transports in the cell. And this hydrogen ATPase will cause secretion of H plus into the tubular lumen to help correct the acidosis. And on the basolateral side, there is the chloride bicarbonate exchanger, and that will help reabsorb the bicarbonate that has been generated through the carbonic anhydrase that is inside the intercalated type A cells. On the flip side are the intercalated type B cells. They have the hydrogen ATPase on the basolateral side and the chloride bicarbonate exchanger on the luminal side, and this is with pendrin. And so if you stain with pendrin, you can differentiate the type B cells from the type A cells as well. And these are the main cells in the management in the body's adaptation to metabolic alkalosis, and they will secrete the bicarbonate in the setting of alkalosis into the tubular lumen. And again, the energy is being generated by the hydrogen ATPase. So in the setting of volume depletion, aldosterone is the main hormone that acts at the distal tubule, and the aldosterone will upregulate the ENaC channel as well as the hydrogen ATPase. And the ENaC channel will cause increased reabsorption of the sodium, and that will generate the electronic potential difference across the luminal membrane, which will drive both the potassium secretion and the hydrogen ion secretion in the distal tubule. And so this will generate both the hypokalemia and cause maintenance of the alkalosis because of the secretion of the hydrogen ATPase. Uh, in addition, the volume depletion will cause decreased chloride delivery, and this decreased chloride delivery will hamper the ability of the chloride bicarbonate exchanger, because there isn't any chloride for the chloride bicarbonate exchanger to exchange. And so the low chloride delivery is also a key in causing maintenance of the metabolic alkalosis as well. So this is how the metabolic alkalosis is maintained in the setting of volume depletion. Now let's look at hypokalemia, and we look at hypokalemia from two settings. One is what happens in the whole body, which is how the metabolic alkalosis is generated, and then in the kidney, which is how the metabolic alkalosis is maintained. So let's take a cell which has a lot of potassium inside the cell, and there is hypokalemia in the blood or in the extracellular compartment, and because of that, potassium is going to come out of the cell to replenish the hypokalemia, and in replacement of that, to maintain electrical neutrality, hydrogen ions are going to go inside the cell. As H plus goes inside the cell, the pH in the blood vessel or in the extracellular compartment will increase and lead to generation of the metabolic alkalosis. Something similar is also going to happen to the cells in the kidney. So let's take a renal tubular cell, and again, If there is hypokalemia in the peritubular capillaries, potassium is going to come out of the renal tubular cell. In replacement, H plus is going to go in, and this is going to make the renal tubular cell acidotic. And because of that, the hydrogen ATPase and the other cellular mechanisms of secreting hydrogen into the tubular lumen will get activated, and will cause hydrogen to be secreted into the tubular lumen and lead to the maintenance of the metabolic alkalosis in the setting of hypokalemia. So this is how the metabolic alkalosis is maintained in the setting of both volume depletion and hypokalemia. Now we will move to some of the causes and mechanisms. And as you can see, the most common causes are vomiting and nasogastric suctioning, in which the factors that are leading to the generation and then maintenance of metabolic alkalosis include hydrogen ion loss, volume depletion and volume loss, as well as hypokalemia. So it's a combination of all of that that is happening. There are rare causes of chloride diarrhea. Most diarrheas have bicarbonate loss, but there are some patients who have significant chloride loss in their diarrhea, which can be a few rare cases of villus adenomas, the congenital chloriduria, in which they can have significant chloride loss, and that chloride depletion and hypokalemia will then cause the metabolic alkalosis and maintain it. Mineralocorticoid excess will lead to hypokalemia and will lead to increased sodium distal delivery, and both of those will lead to the generation and then maintenance of the metabolic alkalosis. And when you look at diuretics or Barter's or Gittleman, there is volume depletion, hypokalemia, as well as increased sodium delivery, and all those factors then lead to the metabolic alkalosis. So in terms of history and examination, most cases are usually self-evident. In the rare situations or the unusual situation in which the cause is not self-evident, examining the body for body habitus and as well as talking to the patient about their sense of their body habitus is important, and may reveal someone with anorexia nervosa or bulimias and diuretic abuse. Looking for signs of the same at their teeth, fingers, knuckles, parotids for any parotitis will again suggest these diagnoses. In the history, asking for any licorice intake and a sense of what they think their body size and shape is, and what their opinion of it is important. And then rarely, as we discussed, diarrhea and whether there's any laxative abuse would be possible for those rare cases of metabolic alkalosis that have alkalosis rather than acidosis. So in terms of evaluation, we'll start with a case. So we have a 30-year-old female who presented with persistent weakness and difficulty in moving. And she has a BMI of 15 and a weight of 50 kgs. On examination, her blood pressure is 90/50. She notes it's always been low. The rest of her exam is unremarkable, including knuckles and teeth, and she denies any laxative or diuretic use. On labs, her venous blood gas shows a pH of 7.5, PCO2 of 46, bicarb of 34. Her sodium is normal, but she is hypokalemic as well, with a potassium of 2.5 and a chloride of 100. So how would you evaluate her, and what do you think is the etiology for her metabolic alkalosis and hypokalemia? So I'll share one of the algorithms of evaluation. The factors that you evaluate remain the same, though the combination in which, or the order in which you evaluate them may be different in different algorithms. So the first thing to consider is to evaluate the urine chloride. If the urine chloride is less than 10, what it means is that the kidney has the appropriate response in the setting of some volume depletion, and the cause is some extra renal loss, whether it is vomiting or NG suction or chloride diarrhea. or it was a renal loss where the renal effect is no longer present. So a diuretic where the effect has worn off. So that is why the urine chloride is indicating the volume depletion that is there following the metabolic alkalosis, and that is the cause. If the urine chloride is more than 20, then the next step to evaluate is their blood pressure and whether they're hypertensive or not. If they're not hypertensive, then usually the cause is that the diuretics effect is on, or it can be Barter's and Gittleman, in which they behave as if they have a constantly on diuretic effect. And so those would be the etiologies for someone who has a high urine chloride and they have low blood pressures as their cause. If you have someone who has a wild swings in urine chloride, that shouldn't happen in someone with Barter's or Gittleman. It would only happen in someone who's taking diuretics, and the effect of diuretic is worn off, and then the urine chloride becomes low. When the effect is on, the urine chloride is high, and so that would be someone in whom you should investigate further for diuretic abuse. If they are hypertensive, then they have some kind of mineralocorticoid excess. And the next step in evaluation would be to evaluate the renal aldosterone levels. So that's kind of the evaluation for metabolic alkalosis. So for going back to our patient, her urine chloride was 80. We discussed with her about diuretics, and she denied it again. We discussed weight and body habitus, and again, she denied she had any issues and felt she was fine. We repeated her urine studies the next day, and her urine chloride came out to be 20. We explained to her that the only explanation for her alkalosis as well as the swings in her urine chloride were some diuretics, and then she volunteered that she was taking some weight loss supplement and which was available over the counter. And on review of that, it was a diuretic. So we'll take another case, a 48-year-old female who is hypertensive for 2 years, but well controlled on amlodipine at 5 milligrams daily. And she came to us with complaints of headaches and was noted to have a severely high blood pressure of 200 over 100. And the rest of her exam was unremarkable. Her lab showed sodium of 145, potassium of 3, and a bicarb of 30, with a VBG showing venous blood gas showing a pH of 7.48. Her urine chloride was high at 75, and suspecting primary hyperaldosteronism, we did a renin and aldosterone level after we corrected her hypokalemia, and both returned low. So what is the cause of her metabolic alkalosis and hypokalemia? So when you have someone who you suspect for mineralocorticoid excess, one of the ways to evaluate is to look at the renin and aldo. And if you have someone with primary hyperaldosteronism, the renin level will be low, the aldosterone will be high, and the ratio will be extremely high to meet the cutoffs for primary hyperaldosteronism. If the renin is high and the aldosterone is high as well, but the ratio is not high, then you have to look at renovascular hypertension or renin secreting tumors or diuretic use, which is causing the renin and aldosterone both to be high. If both are low, meaning renin is low and aldosterone is low, usually it means that there is either an exogenous mineralocorticoid like licorice, or there is apparent mineralocorticoid excess, or ectopic ACTH, or Liddle's, or congenital adrenal hyperplasia. And so then you would have to investigate for those etiologies, or based on history and age at presentation, you may be able to suspect one or the other. So in terms of the clinical manifestations, most patients with metabolic alkalosis usually have no symptoms. This is in contrast to patients with respiratory alkalosis who have symptoms of paresthesias and carpopedal spasms and some lightheadedness. And that is thought to be related to the fact that the respiratory alkalosis with the PCO2 can equilibrate with the brain and cross the blood-brain barrier, much quicker and more rapidly compared to the serum bicarbonate levels, which transfer across the blood-brain barrier much slower and to a lower extent. And so that is possibly why patients with metabolic alkalosis usually don't have these symptoms. They may have symptoms of muscle spasm, tetany, and paresthesias if they have severely low calcium or magnesium, or like the previous patient, severe hypokalemia, that may derive some of the symptoms as well. In terms of treatment, predominantly for those who are volume responsive, meaning vomiting, GI losses, diuretics, or post hypercapnic, giving normal saline and repleting their potassium will allow the kidney to excrete the bicarbonate and correct the hypokalemia and the metabolic alkalosis. If someone has an edema state and the metabolic alkalosis is from diuretics, uh, in that situation, you may have to continue the diuretics for the edema, and then you can add acetazolamide for controlling the bicarbonate. If they have mineralocorticoid excess, the best way is to block based on the pathway. So it may require you to give spironolactone, amiloride, in some cases steroids, or for glucocorticoid remedial hyperaldosteronism, or surgical removal if that is feasible as well. In some patients who have renal failure or advanced renal disease and they have metabolic alkalosis, in that situation you may need to do dialysis, but you'll have to ensure that your dialysis technician lowers the bicarbonate on the machine. To summarize, metabolic alkalosis only develops when the renal excretion of bicarbonate is limited by some factor. The maintenance of metabolic alkalosis is usually due to hypovolemia, hypokalemia, or increased aldosterone, or a combination of the three. Most cases of or most causes of metabolic alkalosis are easily identified on history. For the rare case where the cause is not easily identified, urine chloride, BP, and then aldosterone or renin, if required, should be able to guide you towards the etiology. Treatment is to fix any volume depletion and hypokalemia, and fixing the underlying problem if that can be fixed, and acetazolamide if someone is edematous and needs to continue diuretics. So that's it from my side, and I'll be happy to take any questions.
Thanks very much, Ajay, as usual, for being very clear about various issues that we are confronted with while while we encounter a patient who has metabolic alkalosis. So as you say, Ajay, I think when you encounter pure metabolic alkalosis, it is relatively easy to manage. But can you also maybe talk about some common mixed acid-base disorders in which you have metabolic alkalosis and some other common associated acid-base disturbances, and how will you approach such a situation?
So I think many times there might be other electrolyte imbalances that may be there, and someone, especially with metabolic alkalosis, the hypokalemia is going to be a big factor in that, and that, in my mind, might be something that you have to treat even before you get to the acid base disorder. So in many patients, the first thing to do might be to help replete their potassium even before you address their acid base status. And I think sometimes that might be more important, but sometimes less addressed in these patients. And so I think that would be the first thing to do, because that will also help correct the metabolic alkalosis. Because the kidney's ability to excrete bicarbonate is limited by that. Another iron to keep in mind is hypo and hypercalcemia, because as whenever we give bicarbonate, there is worsening of hypocalcemia, and when the bicarbonate is getting corrected, there's going to be a change in the calcium that binds to the albumin. So that is something to kind of keep in mind if someone has hypercalcemia or has other electrolyte abnormalities that are going along besides the metabolic alkalosis and hypokalemia. And magnesium, whenever someone has hypokalemia, magnesium assessment and replacement would be key to ensuring that the hypokalemia doesn't persist for long periods of time.
Thanks, Ajay. So we have now, I think, Dr. Some questions. I think Dr. Kamal Gopalani wants to ask a question. So I have unmuted you, Dr. Gopalani. Please go ahead and ask your question. Dr. Gopalani, can you, uh, Dr. Gopalani, please go ahead. I think your microphone is not active, so we are not able to hear you. Perhaps you can type your question in the question box, and I can read that out to Dr. Ajay Kher. In the meantime, we have a question from Dr. Shribhushan Raju, who wants to know, will venous bicarbonate be useful in assessment of metabolic alkalosis?
Sure. Venous blood gas and arterial blood gases are going to be, in terms of the bicarbonate, be off by a few points. But to make your diagnosis of metabolic alkalosis or metabolic acidosis or respiratory acidosis, respiratory alkalosis, most of those you should be able to make the diagnosis whether you have a venous blood gas or arterial blood gas. And so I don't think there is going to be a huge difference between the two in the overall diagnosis that you have.
So, so just a follow-up question on that, Ajay. How much do you recommend the people to go and arterialize the veins, before they draw samples for acid-base assessment? Say, for
Uh,
example, warming the limb and things like that.
sure. So I think getting a good sample would be good from the venous, especially if you're looking at someone who's in the ICU in shock. In that situation, there may be a significant difference. But in someone who's in the outpatient or someone who is on the wards, the arterial to venous difference will not be much. In someone who's in shock and on pressors, then there's going to be a lot of difference between the arterial and the venous blood gas, and you're better off getting an arterial sample in those patients. But for most patients in the outpatient, their arterial and venous samples should be pretty similar and should lead to the same diagnosis in the end.
Right. Thanks. Uh, Dr. Gopalani, are you able to ask your question now? Well, looks like Dr. Gopalani still has some audio problems. Any other question from anyone else? I think over the period of last few months, I'm sure everyone will agree that Dr. Ajay Kher has simplified the mystery that is fluid electrolyte and acid-base abnormalities, which sometimes people really dread encountering and managing. But I think over these last few months, Ajay has clarified many of these topics in a way which is very accessible and very engaging, using examples from real life, and also taking those to sort of discuss renal physiology has been extremely, I would say, interesting and a novel way of discussing these somewhat complex problems. So thanks very much for all of that, Ajay. If I'm right, this would be the last one of your talks on the acid-base and electrolyte disorders. Is that
Yes,
right?
this would be the last one for acid base.
So I think I'm sure I speak for all the attendees. There have been hundreds of attendees of these talks. live, as well as they have been viewed thousands of times on the YouTube channel, and I'm sure that many people have benefited from it. So on behalf of everyone, I would like to thank you, and I'm sure we will continue to listen to you on other topics, and we might come back to some specific issues in fluid electrolyte acid base in one of the future talks as well.
Thank you so much, and it's been a pleasure.
All right, thanks everyone. Bye bye.